All rise.
The Court of Clinical Merit is now in session. The case, programmed release paracetamol PA-12 versus conventional 500, 650 milligrams paracetamol and paracetamol 1000 milligrams extended release tablets.
Be seated. We convene not to sell a product, but to weigh evidence, safety, and public health realities. Counsel, your openings.
Your Honor, for paracetamol to actually stop pain, it requires a minimum effective concentration of 3 micrograms per milliliter in the blood. Anything less is a failure for the patient. I represent PA-12, a technological revolution known as the Proglet. It's a bilayer tablet built to lock in that level for a full 12 hours. This isn't just a pill. It's an adherence solution, offering true 24-hour control with only 2 doses.
Your Honor, conventional 500 milligrams, 650 milligrams paracetamol is trusted, inexpensive, widely available, and effective. We will question whether new truly equals better for every patient, every setting, especially where cost, supply chain, availability, and trust matters. We will challenge assumptions about toxicity and explore whether convenience alone should decide the entry of my learned friends, PA-12. The question before the court is simple. Do we really need reinvention of paracetamol or merely reinvention of marketing?
Proceed with the evidence.
Your Honor, I would like to request the court to view Exhibit A. My learned friend calls it reinvention. I call it progress. We are not here to demean the conventional paracetamol. We believe that if science stopped at what was good enough, medicine would never move forward. Innovation exists because patients deserve better than yesterday's solutions. Your Honor, PA-12 is a marvel, as it is a single tablet with 2 layers having different release patterns. The pink layer is 300 milligrams as immediate release, and the white layer is 700 milligrams as programmed release. Thus, Your Honor, PA-12 is the choice for convenience, while 300 milligrams immediate release provides analgesic and antipyretic action within 15 to 30 minutes. 700 milligrams programmed release provides non-stop analgesic and antipyretic action till 12 hours. Hence, my Lord PA-12 has the convenience of BID dosing. Thus, the repeated consumption of my learned friend's conventional paracetamol is avoided. In addition, PA-12 Proglets maintains MEC at 3 micrograms per milliliter for a period of 12 hours, thus providing benefit without pill burden.
So you see how...
Objection, my lord.
Objection sustained.
Conventional paracetamol also offers rapid action within 15 to 30 minutes and is proven for years. My learned friend should know conventional paracetamol reaches a serum concentration of 14.216 micrograms per milliliter within 30 minutes, which is much higher than the MEC. So, my lord, if more is better, conventional paracetamol is doing an excellent job. I don't believe that PA-12 has a case at all. With the court's permission, Your Honor, I seek to submit Exhibit B into the record. Exhibit B clearly shows conventional paracetamol reaches effective levels in approximately 30 minutes too, with 500 milligram dosing every 4 to 6 hours. Isn't fast enough already achieved?
Objection, my lord.
Objection sustained.
If your stomach comfortably handles 1 plate of food, does eating 5 plates give you more energy? Or does it lead to indigestion? My learned friend probably has forgotten that PCM is effective at a concentration of 3 micrograms per milliliter, reaching 14.216 micrograms per milliliter is derogatory, as this would lead to severe adverse effects, whereas PA-12 reaches a concentration of 8.29 micrograms per milliliter within 30 minutes, which is much above the MEC, and thus provides immediate relief with lesser adverse effects. My lord, please refer to Exhibit C. Further, Your Honor, Exhibit C shows that PA-12 is programmed release and releases predictable drug every hour and maintains more than 3 micrograms per milliliter, even after 12 hours. Isn't this a class apart? As PA-12 with a single dose in 12 hours is non-inferior in efficacy to conventional paracetamol, without increasing pill and toxicity burden. Further, unlike conventional paracetamol, PA-12's BID dosage will reduce the peak concentration in the serum, thus avoiding unnecessary drug levels liable to cause toxicity.
Objection, my lord.
Objection sustained.
Your Honor, for over 70 years, physicians have trusted it. My learned friend is trying to dismantle the legacy of conventional paracetamol and mislead our faith with fancy words. He is trying to present this tablet as if it is rocket science. But the truth is simple. Conventional paracetamol works fast and works everywhere. Sometimes, simple solutions are still the best solutions.
If you cannot present a valid argument demonstrating how conventional paracetamol is superior to PA-12, stop wasting this court's time. Objection overruled. Defendant, please continue.
Well, my lord, the world has always moved to smarter choices for convenience and compliance. PA-12 is a hallmark of convenient BID dosage, which improve patient compliance and adherence to therapy. My lord, one of the major concerns experienced by patients is that fever and pain don't follow clinic hours. Patients with osteoarthritis, dengue fever recovery, or malaria-associated aches need consistent control. With 500 milligrams IR, people must wake up to pop a dose at midnight or 2 a.m. If they don't, there's relapse. Twice daily dosage of PA-12, morning and evening, fits our workflow and patient lives. I believe this is enough for Your Honor to pass the verdict.
But do we have evidence that night control is superior?
Yes, of course, we do. I request the court to view Exhibit D. If levels remain above MEC for approximately 12 hours, relapse risk is lower. Clinical non-inferiority trials show similar efficacy versus conventional regimens. The day-to-night continuity is the difference that shifts outcomes from good to trusted.
It is surprising that my learned friend claims trustworthiness by dint of only one clinical evidence. I strongly demand more relevant clinical studies published in the Globe. Why should our patients be burdened to buy such an expensive product for simple non-inferiority benefit?
Objection, Your Honor. My learned friend is trying to waste the precious time and hinder the court proceedings, as she has nothing to prove that conventional paracetamol can supersede PA-12.
Objection overruled. I believe Miss Riley has a point, and I urge Mr. Julius, the defendant's lawyer, to present more robust evidence to prove the trustworthiness of PA-12.
I request the court to view Exhibit E and F. Your Honor, an open-labeled, randomized, multi-center, parallel, comparative clinical study to evaluate 400 patients on efficacy and safety of paracetamol 1000 mg PR tables, PA-12, compared to 500 mg conventional paracetamol tablets in patients with fever and pain. And the conclusion, where PA-12 twice daily showed similar antipyretic and analgesic efficacy compared to 500 mg conventional paracetamol tablets 4 times a day. The study also claims PA-12 superiority as it is required to be administered twice daily with more patient compliance, as it is effective during whole night due to its programmed release profile. This study further confirms that PA-12 is bioequivalent to 500 mg immediate release paracetamol administered 4 times and is tolerated on single-dose administration. I believe with this above evidence, PA-12 clearly stands out. However, Your Honor, to completely silence my learned friend, let me present Exhibit F to the court. Your Honor, in a randomized multicentric non-inferiority trial with 500 patients, published in Pain Medicine 2013, confirms the novelty of PA-12 as non-inferior in efficacy when compared with 500 mg formulation in patients with fever and pain. In addition, Ghosh et al. Concluded paracetamol 1000 mg PR tablet PA-12 has the potential to improve patient compliance as it reduces the administration frequency of oral paracetamol to half. It may enhance paracetamol's analgesic and antipyretic effects.
Well said, and I appreciate my learned friend's evidences. However, why should our patients be burdened to buy such an expensive product for simple non-inferiority benefit over my plaintiff?
My learned friend is reluctant to think about the long-term implication on the patient's liver. Acetaminophen overdose is the second most common cause of acute liver injury requiring transplantation worldwide. With repeated consumption of conventional paracetamol, the chances of liver failure increases, leading to unnecessary hospital stays and higher overall healthcare costs.
Having carefully examined the arguments presented by both counsels, and having reviewed Exhibits A through F, this court acknowledges the long-standing clinical value of conventional immediate-release paracetamol 500-650 mg formulations. For decades, they have provided rapid, reliable analgesic and antipyretic relief, and their role in global public health remains unquestioned. However, medicine evolves, not merely to replace tradition, but to refine it. The defense has demonstrated that PA-12, through its bi-layer programmed release design, achieves critical therapeutic objectives: rapid onset via its 300 mg immediate release layer, sustained plasma maintenance above the minimum effective concentration, 3 micrograms per milliliter, for up to 12 hours through 700 mg programmed release tablet. Ideal for immediate and sustained pain relief with convenient BID dosage. PA-12 is effective for taking care of pain and fever at odd, unexpected hours. PA-12, owing to lower peaks, serum concentration, induces lesser toxicity. The court notes the following established points. Conventional paracetamol achieves rapid and high peak plasma levels, requiring dosing every 4 to 6 hours. PA-12 achieves minimum effective concentration while reducing peak-trough fluctuations with BID dosage. Twice-daily dosing meaningfully improves treatment adherence, especially in prolonged fever and chronic pain settings. Maintenance of MEC reduces the risk of pain and fever at odd, unexpected hours. Clinical data demonstrates non-inferior analgesic and antipyretic efficacy compared to conventional regimens. Reduced dosing frequency may lower the risk of inadvertent paracetamol toxicity. This court does not find that convenience alone determines superiority. However, when convenience translates into improved patient compliance, reduced pill burden, and sustained symptom control, it becomes a clinically relevant advantage. Therefore, the ruling is as follows. PA-12 proglets, by virtue of pharmacokinetic stability, maintenance of MEC providing 24 hours relief with convenient BID dosing, improved patient compliance with reduced risk of toxicity, is recognized as a clinically progressive advancement in scenarios where paracetamol is indicated. The court hereby ascertains the judgment in favor of PA-12, while reaffirming the continued legitimacy of conventional formulations. Let clinical judgment guide prescription, not habit, not novelty.